Our next presenter, Professor Ibrahim Bani, he will be speaking to us today about a field experience in global health nutrition. Professor Ibrahim is a professor in Emory University, United States. He's a Sudanese scholar with interest in health security, and he taught in worldwide from Saudi Arabia to Johns Hopkins in Baltimore to Emory University in Atlanta. Would like to welcome him and would like to listen to him about this, the field experiment. And his main focus is in the health security intersection with nutrition, basically, and that's what he will be speaking to us today about it.
Thank you, Professor Alam and the organizing committee for inviting me to join you this morning. I am going to talk about the experience in global health at different times and at different zones. Today we'll cover first the global health journey with first it includes during my work at the United Nations in Iraq during the oil for food era, during the war, and here this one in which we do observation all over the country for the food, and today we especially talk about the targeted nutrition program. In Sudan, you have Darfur, one of the main conflicts now going on for years and years. There are more, at that time, more than 2 million IDPs and refugees were displaced who are dependent mainly on World Food Program ration to survive. And also it found that micronutrient deficiency is a big problem. Almost 50% of children are affected of anemia, and 36% affected by vitamin A deficiency. And this has initiated the micronutrient initiative, which based in Canada, to start a program in collaboration with the Sudanese Red Crescent and the Ministry of Health for this home-based fortification project. The project components is containing first delivery of a premix from India to Khartoum and then to Niala in Darfur to the IDPs in the camps. And the second component is the training of Red Crescent volunteers and Minister of Health staff in basic nutrition and in distribution of the premix to the IDPs in the camp. And also, the third component is the monitoring and evaluation to see the acceptance and the efficacy of this premix, which is distributed, and also doing training in surveying using a HemiQ for measuring hemoglobin. These are the children in the camp. And the main objective is to improve the nutrition status of the IDPs in the camps. These are 3 camps, population around 32,000. And also the specific objective to test the feasibility of the distribution of this. It's a cheaper premix compared, because at the beginning, macro initiative sort of distributing 2 million packets of macronutrient to the camp, but due to the culture, it found better to use this premix and also assess the acceptability and the efficacy, the impact of this premix. The premix is called Rahma. It was a local name, very common. It's called also meaning mercy in Arabic, and it contains vitamin A, iron, and folic acid to cover the recommended nutrient intake, almost 100% for children below 5 years old. And the premix usually is added to the sauce, to the stable diet, in which they eat porridge and a sauce. It's added immediately after cooking, and they take it during the meal, and all the family eat this premix. Here the overall acceptance in the camps, that is almost over 90%, accepting this premix, which is distributed from containers given to the families, and it is followed every 2 weeks. The efficacy shows that the main impact is in the hemoglobin level, is increasing the hemoglobin level up to almost 13, and it is highly significant. And also it was studied in women of childbearing age. It's also, there is an increase, but not significant. Another life mile is the iodine deficiency in the Kingdom of Saudi Arabia. This is another zone in which I have been there, and as in capacity of an academic institution doing a survey in iodine deficiency, which is important that they use universal salt iodization to prevent IDDs. And in this survey, which was done in the southern part of the Kingdom of Saudi Arabia, the main population is children, and in schools, in 12 schools were selected at random, 6 schools for male and 6 schools females, and 30 students were selected from class. The main objective to identify the prevalence of goiter, and at the same time to analyze urine iodine concentration to determine the prevalence of IDD, and also to analyze the iodine as a salt, because each child brought about 30 grams of salt from home, and this to provide a baseline data for this project. And here, as you see, that although there is utilization of iodized salt, only about 46.9% use adequate iodized salt in their home. Here, this survey showing that in the kingdom there is, at that time, this is in 1997, 20 years ago, the goiter is about 4.2%, and the southern region was 12.5%. And here in this study shows mainly that goiter is in the mountainous areas compared to other coastal or plain areas. And he also shows the IDD is mainly also in the mountainous areas compared to other areas in the region. So almost 100% of households use iodized salt, but only 46.9% use adequate iodized salt. Adequate means containing 15 to 40 ppm. Here the Saudi organization standard organization recommendation is high. It's 70 to 100%, and this is why even we have some iodized salt in the market called ZAD. So you have high, compared to the UNICEF and WHO recommendation should be 15 to 40. But after this survey, they changed their recommendation, and now they're using the WHO recommendation side. The Target Nutrition Program is one of the United Nations program, especially following the Gulf War in 1991, following the sanctions, and the UN has sending a mission found that there is an increased high risk of malnutrition, and started thinking of holding this through the Oil for Food program, and the Iraqi government did not approve until 1996 the Oil for Food program. And the main is that providing of humanitarian assistance, because there are about 24 sectors of humanitarian needed, including water, electricity, food, and they moved from emergency to development, this after the Gulf War. And nutrition observation, in which the sector in which I used to do nutrition observation all over the country, in which we visit all primary care centers, all hospitals, to see the distribution of medicine and food, and to see the impact of the humanitarian program. And the targeted nutrition program, it started actually after the Oil for Food in 1998, in which fortified biscuits were distributed to children below 5 years and school children plus women of childbearing age. And you see here, there is community care units in which they screen children, and these children were referred to primary care centers to confirm whether they have malnutrition and severe, especially severe malnutrition. And then they will refer to hospitals for rehabilitation, and after rehab, they sent to the community and so on. And this group have been also targeted by fortified biscuit. This shows the impact of the status of Oil for Food program in 1996, in which nutrition status had been dropped. You see here. If you take acute malnutrition in 1991, following the war for 6 years, there is peak 1996. Then after the Oil for Food in 1996 and 1997, then it started to drop down, acute malnutrition, chronic malnutrition, although dropped, but it's still high. In conclusion, that deterioration trend of malnutrition arrested, but still at high levels. So it is an outcome of multiple factors, malnutrition beside these conflicts. So in conclusion, to this global health experience, it's mainly in conflict regions in Darfur, in Sudan, and in Iraq. And this one of the main things related to the Sustainable Development Goals, one, in which is no poverty, and because of the conflict leading to poverty, and no hunger also due to conflicts. Thank you.
So please remember, if we all help and do a little bit, it will make a big difference.